Kia ora. Welcome to day 7 of the COVID-19 Masterclass. I'm Jackie Haddingham, Manager of the Otago Global Health Institute, OGHI for short. Today's webinar will last for 1 hour. We'll finish at around 1 p.m. New Zealand time. Our webinars are being recorded and will be available on the OGHI website later. We are also live streaming through the OGHI Facebook page. During today's webinar, we'll have one 45-minute presentation session by all 3 speakers, followed by a 15-minute question and answer. You can ask questions and answers at any time through the Q&A function at the bottom of your screen. After the presentations, I'll read the questions aloud for the speakers to reply. As always, if we're not able to get through all the questions, we'll ask the speakers to provide written responses, which we'll then post on the OGHI website. So, to today's speakers, Dr. Ayesha Verrall is an infectious disease physician and epidemiologist in the Department of Pathology at the University of Otago, Wellington. Dr. Susan Jack is a public health specialist and epidemiologist and is a medical officer of health at the Southern Regional DHB. Dr. Andrew Chen is a research fellow with KOI2, the Centre for Informed Futures at the University of Auckland. Over to you, Ayesha.
Tēnā koutou katoa. Today I'm going to discuss the experience with contact tracing in New Zealand and work I did to evaluate our contact tracing system. And as part of that, we're going to define what good contact tracing is and set out an evaluation framework. If you don't already know, I'm a Labour list candidate for the general election, so please bear that in mind. So contact tracing is an established public health method that's used for a variety of communicable diseases as part of control. For COVID-19, contact tracing is the identification and isolation of people who have been exposed to an infectious case, and that prevents onwards transmission from the contact to others. Contact tracing for other illnesses leads to other interventions. So, for example, in tuberculosis to prophylactic treatment, and in some other illnesses to vaccination. So New Zealand has a contact tracing system that is devolved to public health units in 12 and there are 12 of them across the country. Contact tracing is performed routinely in these units for diseases like tuberculosis and during other outbreaks, so pandemic influenza H1N1 and mumps and measles outbreaks in recent years. We know from the H1N1 influenza pandemic that an enduring problem has been fragmented information systems. So public health units each have their own contact information system, and this can be quite sophisticated in those public health units that are supported by large DHBs, but in smaller public health units that's not the case, and it's hard to share information across the system as a whole, or to get good data for reporting. So this is for contacts. It's in contrast to cases for which we do have a national notification system called EpiServe. I said that public health responsibility is devolved. There is a emergency management plan for public health emergencies, but also for civil defence that requires an all-of-government response. But the operational arrangements for coordinating parts of the public health response, like contact tracing, were not defined in those protocols. Before we talk about how the system can be evaluated, it's worthwhile just to set the context with COVID-19 in New Zealand. And please remember that when we started our pandemic, we probably had the capacity to trace just 10 cases and their contacts a day. And that's from cabinet documents that have recently been released. New Zealand diagnosed its first case of COVID-19 on the 28th of February, and there was a rapid effort to expand public health unit capacity by redeploying staff for contact tracing. Through March, we saw an increase in cases and the development of local clusters at the end of March. On the 20th of March, our borders were closed except to returning New Zealanders. And there was a rapid escalation through alert levels, and on 24th of March, an alert level 4 lockdown was introduced to prevent an outbreak. As we went into that lockdown, we were at about 60 and then more cases per day. And at that stage, official documents also reflect that the capacity for contact tracing was probably about 50 cases per day, with the additional resource that had been moved into public health units. At that point, a national close contact service also came online, which was a call centre based service in the Ministry of Health, supported by, well, initially supported by paper-based procedures and later in a digital information system. So that started just as we went into lockdown, and I was asked to audit the contact tracing system on the 10th of April. So in preparation for that, I sought to define what good contact tracing is. And we can say that if we want to make a difference to the outbreak or to the pandemic, we need to achieve an R0 of less than 1. So contact tracing should achieve that. And from these two modelling studies that were published at the time, which each use slightly different assumptions, we can say that speed and the completeness, so the number of contacts who are traced, are key measures that we have to optimise to achieve an R0 less than 1. There's also a related concept of capacity, so that's, I guess it's related to completeness. And this has really been part of our discourse in New Zealand right from the very beginning, because many of us drew attention to the fact that the capacity in our system was limited and not up to the exponential growth that an outbreak that would occur with a pandemic. But it's become clear talking to international colleagues that a lot of them are being asked to contact trace when they don't have the capacity to trace a third of the cases they have in their population. And that's very demoralising for public health authorities to know that they're doing this without having much impact on the overall course of their outbreak. Another important characteristic of contact tracing is the effectiveness of quarantine. The whole purpose of the process is to put people in quarantine, so unless that's effective, it won't work. And then other aspects which are important but might be hard to get quantitative data on is the acceptability to the community, the ability to integrate disease control with welfare objectives, and the and that it has equitable outcomes. So we can build a conceptual model of contact tracing that allows us to think of how we would measure these different characteristics of a contact tracing system. So I think we should view contact tracing as a process that encapsulates all the event for a case through to their contacts. So you can see here in this model, we have an index case who develops symptoms. They present and have a sample taken, a diagnostic test is performed. This is reported to public health authorities. They begin a case investigation, and then they trace the contacts and quarantine them. And we can see from the colour coding here that different parts of this process relate to different parts of the health system, at least in New Zealand. So here, the process from symptom development to a test being taken is dependent on community understanding of the illness and access to testing. The turnaround time of a test is determined by laboratory performance, and the case investigation and contact tracing is performed by public health units and to some extent the National Close Contact Service. So at each stage of this process, we could measure timeliness, completeness, and capacity, and a good information system would capture cases and link their data to all their contacts, and as each step was completed, generate a timestamp, and that would allow us to monitor the performance of the system. And then we can break down into detail measurements of the contact tracing process. So the first is the capacity as a whole, which isn't really a performance indicator, but does need to be known. It does change over time, and unless you know the capacity of your system, you can't make decisions during an outbreak about how to allocate resources and work across the country. Then the next two relate to access and timeliness of testing, so shaded in purple, and you can see that, so you can measure the time for a person's symptom, a case onset of symptom to testing, and also the proportion of those who meet the case definition who have a test done. That one is, the second one is quite a hard one to measure in practice because it requires having a knowledge of a denominator who don't present to the health system. So in practice, you might have to use a proxy measure of testing like positivity rate to address that data point. Laboratory turnaround time is another key performance indicator. And then in public health units, there are 4 important measurements to track. The time from the public health unit notification of a case to contact identification, and the proportion of all the contacts who are traced. Then the time from contact identification to quarantine, and the proportion of contacts who adhere to quarantine. And for each of these, you can name a target or a threshold that should be reached. And I propose these in my report to the Ministry with an overall view that we should be trying to trace 80% of contacts within 3 days of the case onset of symptoms. And that overall performance indicator is based on modelling, which is limited, and obviously this work was done early in the outbreak. So I do expect that these should be revised as we have more real world information. But we'll only have real world information if we measure outcomes. So what is the actual public health impact of contact tracing as opposed to the measures of the process that I just described. So one that we've proposed is the secondary transmission rate. It should be less than 1%. So that secondary transmission is from the contacts, transmission from them to their contacts. So that's the event that contact tracing is trying to prevent, and it should be low. Also works with Alex James and others in Te Puna Matatini to look at measurements that best correlate with the R0. And from that work, this has been proposed, the proportion of cases quarantined within 4 days of quarantine of the index cases could be an alternative indicator. But the point is that modelled targets that might be inaccurate, they may be excessively strict actually, and we should be looking for real world data to help revise those. So following my evaluation of the contact tracing system, I recommended a number of changes, and especially to expanding our capacity both at a regional and national level, and I sought to have a real emphasis on the exceptional job that public health units do in terms of knowing their communities and being able to initiate an appropriate response at a local level, but that they need backup nationally. I also sought to recommend that their preparations be made for further outbreaks, including the development of an outbreak plan that would address up to 1,000 cases, plan for contact tracing 1,000 cases in their contacts a day. And importantly, to determine how work would be allocated across the system, either to other public health units or to the centre in an outbreak, and the protocols that would allow that work to be shifted. I argued for stricter supervision of home quarantine and the development of a contact tracing app, which Andrew will talk about. And one of the key recommendations was really to try and improve the contact tracing information technology systems, and the National Contact Tracing, National Close Contact Service, the call centre in the ministry, had a really good IT system, and I recommended extending that in 2 directions. So firstly, to allow public health units to access it so that they could see where work that they referred to another place was at and had in fact been acted on, and contacts they hadn't traced were being traced by someone else. And secondly, upstream, to capture those case and laboratory events that have flow-on effects to the timeliness of contact tracing. So we now have in New Zealand a contact tracing action plan that is nationally coordinated and and that in itself is an achievement, because previously it was a devolved system. The National Contact Tracing Solution, so the software, is being extended to public health units. That's ongoing work. And other recommendations about the outbreak preparedness and so on is being overseen by a ministerial committee. Excuse me. I won't go into detail of this, but before published, the use of the National Contact Tracing Solution allows performance to be monitored in real time. However, we have very few cases at the moment, so every 2 weeks the Ministry of Health is reporting on contact tracing performance using the measures that we've recommended. Before concluding, I wanted to mention about where we could where there's still room for further academic work and thought to assist improvement of our contact tracing system. And I think understanding the meaning of clusters is a really important part of this. So just remembering that although the R naught for COVID is 2.5 or 2, the most cases infect 0 or 1 contacts, and a few will infect 2 or 3, and then there is rare but important super spreading events which may in fact infect 10 or 20 contacts. And so what that means is that there's in fact often greater yield in the case investigation and finding out how the case was infected from upstream than necessarily in contact tracing, though of course you should do both. And that process of identifying whether or not you are dealing with a cluster when you find your first case is one that we need to make sure we support better. So this report by Allen and Clark, referenced down the bottom, pointed to the need for better IT to support cluster identification. But we also need to think about when public health unit is thinking whether they're potentially on the edge of discovering a cluster, what could they do to really get ahead of the curve there? One option, which would be highly work intensive, is to trace second order contacts. Another might be to think about particular scenarios in advance and think whether short-term targeted restrictions while you determine whether you're dealing with a cluster or not is appropriate. So for example, if you had one case in a school, would you close down the school, or similarly in a workplace just for a couple of days to do testing? So I think that's the next area where we need to optimise the contact tracing procedures. So in conclusion, New Zealand's contact tracing capacity has been substantially strengthened, and we have a national program with the Ministry of Health coordinating and developing the information technology infrastructure. Technology has enabled a high level of transparency with reporting of performance, which is overall a good thing and has driven a lot of the improvements. There's also been a change towards a preparedness mindset, but we can always work to improve the detail with which our preparations are made, and that's why I'd particularly like a focus going forward on how to address clusters.
Thank you, Ayesha. Susan.
Okay, thanks very much, Ayesha. Tēnā koutou katoa. So, as has been mentioned, I'm a public health physician, medical officer of health, and the clinical director of Public Health South at the Southern District Health Board. So the second part of the talk is really going to look at local perspectives for case management and contact tracing. So you'll all be very familiar with our numbers in New Zealand. These are the numbers as of this morning. But I just wanted to highlight that there were different incidence rates across New Zealand, and the southern region was probably the hotspot. We had the highest incidence in New Zealand, and I'll be talking a little bit more about that in a minute. You'll also be very familiar with New Zealand's approach from our pandemic plan. And so we're really focusing on this early recognition, case finding, contact tracing and isolation part of it. And you'll also note that this New Zealand approach for a pandemic plan also aligns with our elimination strategy that we have for COVID-19, where we have border controls, the 4 pillars of border controls, robust case detection and surveillance, effective contact tracing in quarantine, and then those strong community supportive control measures. So physical distancing, hygiene, cough etiquette, and PPE wearing where appropriate. So what happened in Southern was that, like many of you, we were watching what was happening in Wuhan in China. And from late January, we started our Emerging Infectious Disease Coordinating Committee, which was a group across the DHB. And we were meeting daily just to monitor the global situation and to watch and see if New Zealand was going to be affected. As you all know, we were. And in Southern, we got our first cases in mid-March. So at that point, we merged into a technical advisory group. We set up an emergency coordinating centre, and out of that we had various emergency operating centres. So one for the public health unit, one for hospital level care, and one for primary care. Our public health staff worked across our 3 offices across the region, in Dunedin, Invercargill and Queenstown, and also working remotely from home. During the early phases, we were also being asked to support the border response. So several of our health protection officers were needing to meet all planes coming in to both our Queenstown airport and the occasional international flight that comes into Dunedin. Our operating model evolved, but initially we used existing communicable disease protocols that we had used for our recent measles outbreak. In fact, our measles outbreak really gave us a good dummy run for COVID-19. We already had experience in setting up an EOC. We had experience in having teams working on the contact tracing and case detection and so forth. So it wasn't a new thing, it was just at a much higher level. You'll probably also be familiar with this set of graphs looking at across all the DHBs, the number of cases and when they came, and just highlighting again Southern. We had a large number of cases, 216 in the end, but probably more important is that we got most of our cases over an extraordinarily busy 3-week period, which of course put a huge stretch on our resources. This is a heat map of the distribution of cases. And again, we had cases all over our very geographically dispersed region with hotspots, especially in Queenstown, Dunedin City and Invercargill. This meant that remote management capability really was absolutely essential. We already do most of our work for infectious diseases remotely by telephone, so it wasn't a new thing for us, but it just does highlight some of the capabilities that you need to make sure are in place for managing outbreaks like these. So this is a very simplified diagram of what happened at Public Health South when we got cases. So we had a very close working relationship with Southern Community Labs and quickly set up systems where they would report to us new cases twice a day. We used to get an email at 6 a.m. At 8:30, we would have a case management allocation meeting where we had the number of new cases, we would allocate them out to case managers. They would then go off and call the cases. What we discovered early on as well was that cases, it's often quite a shock to be told you've got COVID-19. So we would need to call them, give them 15 or 20 minutes to get their heads around that, and then call them back to continue the scoping, which involved finding out where they'd been, who they'd been in contact with, how big their contact list was likely to be. And it must be pointed out that before lockdown, some of our cases had upward of 150 close contacts, some 90, some 30, 40. So in the early days, it was extraordinarily busy getting those lists of contacts and then finding them all. So at 11 a.m. each day, we would then have a meeting to look at going through each case. So each case was discussed. We would look at their clinical risk assessment, how many contacts they had, and then those cases were allocated onto contact trace leads who would then work further to get lists of the contacts, determine the exposures, the contacts, and like Ayesha pointed out, work out if they might be part of a cluster. The contacts were then allocated to a contact trace team They were called, they were instructed that they needed to be in quarantine, and then daily monitoring with symptom checks was initiated. Early before we went into lockdown, it was very much informing people that they did need to be isolated. Of course, when we went into alert level 4, this became a lot easier. So as I said early on, we had large numbers of contacts. When everybody was in lockdown, apart from essential workers, all of our cases really only had their households as close contacts. So the numbers were vastly reduced. In parallel with that, our cases were handed over to case monitors for daily monitoring, and that could be done by telephone or by other IT means that I'll describe in a minute. So what IT systems did we use? Well, in the very early days, we were calling each case to the ministry. They quickly became overwhelmed with increasing numbers. So EpiServe became the single source of truth. We would load our cases onto the case report form there, and that was what was used for the daily reporting by the ministry. We also set up a master spreadsheet for all confirmed and probable cases, and we'd used this very successfully during our measles outbreak. And on the master spreadsheet would go essential bits of information, names, NHIs, onset dates, and so forth. The case monitoring could either be done by telephone, which was then recorded on another spreadsheet. Later on, we used red caps that ESR had set up for contacts, which is an IT survey that you can send out by email, ask people to fill in the symptoms or whatever that they have that day. It's returned and then reviewed by one of our contact tracers or case monitors. So contact tracing initially was done by telephone, but then we very quickly moved to red caps, which was a whole lot more efficient. It must be noted, as Ayesha has already pointed out, our IT systems were not, did not interact with each other. We're not a large public health unit. We didn't have a dedicated IT system for this. So if we needed to find out information about a case or a contact, it required looking up multiple sources on our shared drive to find that information. As Ayesha also referred to, there was a rapid appraisal deep dive report. So 3 public health units were selected for a deep dive analysis of our contact tracing. And these reports are available for you to read, but just the highlights demonstrated what we had to go through in order to get our system very rapidly set up. So we had training packages, we had documents with roles and responsibilities and instructional guides. Our training packages were delivered either face-to-face early on or then later by Zoom and on YouTube. We used a champion system where we had less experienced staff buddied up with more experienced staff, and our staff really appreciated this approach. However, because, like I mentioned, we had so many cases hit us all at once, this was very difficult to do when our very experienced staff were totally under the pump and then having to train new people as we went along. In the end, contact tracing training was given to over 135 people. 100 of the staff were actually deployed, and many of, well, some of these were our own health protection officers and health promotion advisors in our public health unit, but we do want to do a big thanks to everybody who was involved with this. We had staff deployed from across the DHB. We had staff from district councils, environmental health officers who were also trained and involved. We briefly used the services of the National Contact Tracing Service in mid to late March, but it was a less than optimal experience. So we stopped using that until those national systems could get better put in place. However, there was a very broad view expressed that technology could indeed significantly increase our efficiency, and we did recognise the value of a national single system. So some of the lessons that we learnt during that time was that as case numbers increased, so did our need for oversight of daily monitoring of contacts, and especially clinical oversight of our cases. New Zealand decided early on that all cases that could be managed at home would be managed at home. this actually put an enormous strain on our clinical people who were leading that. So we only had nurses to do that role because we felt, because they were dealing with a brand new disease that we were still all learning about, that it was, in terms of risk management, it was much better to have someone who had a clinical background to be doing that assessment. We also learnt that high-risk cases, so older age or with comorbidities, should be called rather than using electronic responses. And this again was so that we could manage that clinical risk. And also coupled with that is talking directly with cases. We often had helpful family members who wanted to take the burden off their loved one who was unwell. But in terms of doing a clinical risk assessment, it's much, much better to talk directly with the actual patient. So what has happened since then? All of our cases have recovered. We had 2 that very sadly passed away. But now the Ministry of Health, as Ayesha indicated, is looking forward to what if we have another surge. So all the public health units are being asked to develop their capacity uplift plans. And following on from Ayesha's recommendation that New Zealand should be prepared to be able to manage 1,000 cases a day, half of these have been allocated to public health units and half to the ministry central systems. So each public health unit, depending on your population, have had that 500 cases divvied up. So for Public Health South, we are being asked to be able to manage up to 34 cases a day should we get a second surge. So we did some modelling. The grey line is what actually happened in our outbreak. And at our peak over those couple of days, we were seeing between 9 to 19 cases per day, new cases per day. But what we've been asked to plan for is up to 34 cases per day on a more sustained manner. We've been told not to expect that we would necessarily go back into lockdown alert level 4, but to plan as if there wouldn't be any lockdown, which means that obviously that has an impact on the number of contacts that we might need to be tracing. So the National Contact Tracing Solution, as Ayesha has described, is this integrated system both for case management and tracing. Cases are loaded into Episerve, it generates a case into the system. Case details are entered following the case scoping I described earlier, and then contacts are entered per exposure. So this means an event, which hopefully would be able to alert us to if there might be a cluster emerging, or a household or a workplace. And then there's an automated system for the daily monitoring, which is similar to REDCaps, but is integrated into the National Contact Tracing Solution with that option to call if we deem that necessary. So in Public Health South, we do plan to use the system if we get more cases. We've already had a lot of training from the Ministry of Health team. We've got a couple of super users, a data analyst trained, and training of all of our staff is now underway for case managers and monitors, contact trace leads and contact tracers. Right now, because we are not having any cases, we're using scenarios to try and maintain competencies. Now, I'm not expecting you to be able to read any of this, but I'm just wanting to highlight how complex case management and contact tracing actually is. Each of these different colours represents a different role in that pathway. Here is where you start when you have a new case reported, and then it has to go through all of these systems to properly manage a case and manage their contacts. When we've done modelling to look at what daily full-time equivalent staffing would be required to manage this kind of response, we've realised we're going to need 127 full-time equivalent to manage it. We don't have that number in our public health unit, so we'll be looking for staff from across the DHB, some community agencies to be deployed to help us with this response. As I said, we feel that case managers and monitors must be nursing or have a medical background. Contact trace leads and staff can be other staff. leads can be other staff, but IT literacy, excellent communication skills, excellent record keeping skills, and that ability to work under pressure are absolutely essential. So I'm going to hand it over now to Andrew.
Thanks very much, Susan. You might just have to stop sharing yours and then I can share mine. There you go. Hopefully everyone can see that. I think that's working. Tēnā koutou katoa, ngā mihi nui mō te kōrero. Thank you very much, everyone. So I'll be talking about some of the digital technologies that we've been considering for contact tracing, both in New Zealand and around the world. It's important to say that I'm not an epidemiologist or public health expert. My background is in computing and ethics and understanding how digital technologies are impacting society. And so I think that it's pretty natural for people to look at the world around us and to see how integrated technology is now in our everyday lives, and then to look at the manual contact tracing system, which is doing the best that it can, but it's relying on phone calls and in some cases out-of-date contact details. And it's natural to ask, could technology make this better? So I think it's important to note the use of IT to help support manual contact tracing in terms of the IT systems that both Ayesha and Susan have talked about, but also the potential for digital technology to help improve information collection and get information from people to the right places. But before we decide on what technology we should use, we need to understand the problem and what the technology is supposed to do. I won't spend too much time on this because we've already talked about contact tracing and what it means. But effectively, you've got a case, you get somebody to interview them, they can tell you about people that are known to them, so family members, work colleagues, and so on. The hard part is when you get to people who are unknown to the patient, and you want to be asking questions like, where was the patient at what times? Who else was there at those times? What risk of exposure was there for those other people? And we might call this completeness as a way of measuring all of the possible context for a particular case. The other aspect is that we need to do this identification and isolation as quickly as possible. If we can get people to isolate earlier, then the modeling shows that they won't be spreading the disease as much, and it means that we can reduce the spread of the disease, so we need to act fast. And so these two characteristics, completeness and speed, are really what we want to be targeting with any technical solution that we introduce. So now we can look at some of the different technology options. And I think a lot of people have been talking about apps or the app. The app is just software and it needs to get its data from somewhere. So when we ask the questions like, where has the person been at what times and who else has been there, effectively that question is one of location tracking. So there's a class of technologies, GPS, Wi-Fi signals, cell tower localization, where we're using signal strength from a device like a smartphone relative to a known point, and then we can figure out where they are. And I call these high granularity tools because we might be able to determine the location of a person once a minute or once every 5 minutes. And that would give us a relatively high detailed track of where that person has been and who else has also been there. The other class is are these QR codes or texting in or using sign-in forms, essentially asking where and when did a person check in to a known point. And these would be low granularity because in most cases we'd be finding maybe 3 to 5 check-ins per person per day on average. Interestingly, overseas, and in the context of this particular pandemic, we've seen a lot moving towards this proximity or contact detection. So instead of asking where people have been, the question is more, who have they been close to? So we have protocols like Bluetooth and Bluetooth Low Energy or Internet of Things protocols, which are really short range signals. So they're not suitable for location tracking. But the idea here is that you can have a device exchange a signal with another device, and then you can measure proximity between those two devices based on the signal strength and the time. And then we just assume that people are carrying those devices. So if the devices are physically proximate, then presumably the people are as well. Another category of technology options to also note is this use of higher tech solutions for investigative surveillance. So the use of CCTV, facial recognition technologies and biometrics, going through financial transaction data, conducting virtual interviews. These are still mostly manually driven methods, but they're using high tech to get high quality information out of these systems beyond just doing an interview with a person. So moving on from sort of the technology options, I think The same characteristics of the technology that allow it to achieve completeness and speed, unfortunately also allow poor actors to accumulate data and use it for poor purposes. And so we need to ensure that the use of technology for the public health response is balanced against protecting the privacy of people. We are worried about privacy when we've got the manual contact tracing system, but that privacy question needs to be asked in a different way at a different level when we start to introduce more technology into the picture. So we want to be asking what information is being collected. We've got some pretty standard stuff in terms of names, date of birth, phone number, etc. But when we start to consider also that we're collecting health and symptom data and location logs of where people have been and their timestamps, the accumulation of all of this data could be used in really poor ways by poor actors. So some other questions that we need to be asking are things like who gets to see that information, what purpose is that information being used for. Governments have been generally pretty good about limiting the use of this information for public health response only, but that's the legislative side. We need to have appropriate checks and balances and also ensure that there are good data governance and oversight processes as well if we are going to collect this information. Another important question is around when will this information be destroyed? So most of these systems are deleting location logs after 1 or 2 months because they are no longer relevant to contact tracing. However, some places are keeping anonymized or aggregated data for analysis and research purposes. And this is going to be really useful after the fact to understand how the virus spread, which communities were most affected, and so on. And there are a bunch of other policy considerations that we need to take into account beyond just which technology we choose. So one of the key ones has been whether the system is going to be voluntary or mandatory. Most places around the world are using a voluntary system, which has meant that the uptake rate has been challenging to achieve. So depending on who you talk to and which study you read, you need something between 40 and 75% of the population contributing useful data for a digital contact tracing or automated contact tracing system to be useful. And most of the systems that we're seeing now are only achieving about 20 to 25% uptake. You also want to consider whether this is a universal approach or a targeted approach. Are we trying to deploy this technology to all people in the population or just focusing on those who might be more vulnerable? And we also want to be considering things like if we're relying on smartphones as being the primary piece of hardware that we're going to do contact tracing with, then we need to understand who might be left out if we deploy a system. And so it's really common around the world that if we're relying on smartphones, then there are going to be elderly populations who don't have smartphones, or who don't know how to use smartphones, and they actually are the people who are the most vulnerable to a disease like this. So we need to ensure that there are other interventions in place and not just assume that adding technology to contact tracing will magically solve everything. And of course, more data means that we need storage and security as well. There's been some debate about storing data locally versus offshore in the cloud. This is to do with the fact that data legislation and the jurisdictional effects of where the data is physically located actually matters, even though nowadays we sort of just send data all around the world. And we also want to ensure that we're encrypting that data, both in transmission and at rest, and that we're doing independent security audits to make sure that the system is not going to be abused by third-party actors who may have poor intentions. So I'm just going to go through a couple of case studies of how this technology has been used in different countries, and just to show the variety of different approaches. So Singapore was first off the bat. They came out with Trace Together back in sort of March, April. Smartphones exchange Bluetooth signals with each other to record proximity. As someone tests positive, then the Ministry of Health requests that they give them that proximity data. The Ministry of Health has a database that says these devices are connected to these phone numbers, and then contact tracers will manually go out and call people who have had a risk of exposure and advise them on the next steps. So they targeted a 75% uptake rate. About 2 months later, they only achieved about 25%. And to be honest, it sort of sounds like that they've given up on this, but they can't actually say that because they need to maintain trust in the system. But they are moving towards using other systems. Recently, they announced that they're going to be deploying 300,000 wearable bracelets that are compatible with Trace Together so that they can target specific populations that may not have smartphones. Australia's COVID Safe app is based on a similar technology and method, and they've been having some similar issues to Singapore in recent weeks. Singapore's now also released Safe Entry. So this is a QR code system where people need to go and scan the QR codes. It's mandatory for all businesses to display a QR code, and some venues are even making it compulsory to scan the QR code before they'll let you in. And all of the data in the system is stored centrally. So as people are scanning the QR codes, that record is being sent to a government server and stored centrally so that it can be analyzed by the Ministry of Health. In Poland, we have a very different system. So they have a mandatory home quarantine app. This is to help ensure that people who are supposed to be staying at home are at home. So the phone is using the GPS to monitor the location of the phone continuously 24/7. And then users are prompted throughout the day to take a selfie, basically to verify that they are with their device and they haven't left the device at home and sneakily gone out. So they will get a notification, and then they have 20 minutes to respond to a request to take a photo. Facial recognition is used to verify that the person holding the phone is the person who should be holding the phone. There's a financial penalty if you don't comply, and if you choose to opt out of the system, then you get police visits multiple times a day instead. They also have a voluntary app for everyone else called Otago Safe. And so this app has a risk assessment test to help people understand if they are at risk of COVID-19 or another respiratory illness, and also has a health journal to help people keep track of symptoms. So this is just showing that sometimes you can bundle in other features into these sorts of apps to provide more value to the users and give them more reason to be participating. And then this app also uses Bluetooth proximity detection. Instead of sending all of that data to the cloud, it stores the data on the device for 2 weeks. And the Ministry of Health can send, can provide exposure notifications, so it can send data to the apps to say, this device is one that has been exposed to COVID-19. If your device has been close to that one, then maybe you should get in touch with the public health officials. Closer to home in New Zealand, pretty much after level 4, when we went to level 3 and 2, businesses had to keep contact tracing registers. That was mandatory. There were some notable exceptions, such as retail. And effectively, initially, this was just pen and paper register template that was released by the government. Of course, private developers then came in with QR code systems, and this is really to address 2 things. 1, to help people enter their data more quickly, and 2, to reduce dirty pen risks where everybody's using the same pen and then that pen becomes the vector for transmission of the disease. It also helps reduce some of those privacy risks in comparison to a pen and paper register where everybody's details are out publicly for anybody to see. The government then released the NZ COVID Tracer app. So this was also QR code based, and the QR code is generated based on the New Zealand business number. So it's unique to each specific location. The data stays on the device as the government has characterized it as a digital diary for the individual. They've then added on the ability for you to electronically share your log of times and places to the Ministry of Health if requested to do so by a contact tracer. This is voluntary. And then the Ministry of Health can also push out exposure notifications to say, this time, this place, there was a serious potential for exposure. Check that against the logs in your app. If you were there at that time, you get a notification saying, maybe you should go home, maybe get a test, call Healthline if you're concerned. I just also wanted to quickly touch on the Apple and Google protocol, because this is getting a lot of traction around the world. So Apple and Google banded together. Collectively, they the operating systems that they've developed account for 98% of the smartphones around the world. So there's real opportunity for interoperability here, where you don't need to worry about compatibility issues. And interestingly, it'll allow for cross-border contact tracing, which will be really important if we want to open up the borders again. So like many of the other solutions, it uses Bluetooth handshakes to record proximity. And importantly, each government has to develop an app to interpret those signals and provide local information. So provide a local phone number, but also they can tune what is considered to be a close contact in a way that is relevant for that local context. Interestingly, the privacy restrictions and coordination requirements have been set by Apple and Google rather than by the governments. So they've done things like saying location services must not be used, and that governments must only use the data for the public health response. And at least at this point, there's about 3 US states and Switzerland that are adopting it. More and more European countries are considering it. there have been some concerns that using the system means that it's sort of happening autonomously off to the side, and that the public health officials aren't quite getting enough information to be able to monitor the spread of the disease. I just want to make one final point about usability. I think one of the things that we've learned from this experience so far is that, particularly when we're talking about voluntary systems, if it's not simple, people won't use it. And I sort of had to skip through this. I just rest on that last point there. In terms of integration, what I think is that any solution needs to integrate with the manual contact tracing processes. If the data that is produced by these systems is not useful or not interrogable by contact tracers, then it'll probably just be ignored. So we need to be designing these systems in conjunction with public health officials, not independently. And we want to be keeping in mind that these systems are here to augment rather than replace manual contact tracing where that manual contact tracing is good. So just to conclude, I think the theory and logic of using technology for contact tracing is pretty good, but is relatively untested in the real world. We have very little evidence of effectiveness so far. There's very limited evidence of it being effective before COVID-19. And it's really complicated, right? Because it's not just about choosing a technology option. There's a lot of other non-technical considerations. The interesting thing will be that digital contact tracing is this big experiment. All these different countries have selected different approaches, so we'll be able to have a really good idea afterwards of what worked and what didn't work. Thank you very much, and I'll hand back to Jackie for questions.
Thank you, Doctors Verrall, Jack, and Chen. Andrew, seeing as we have you up last, there's a specific question which comes through particularly for you. Andrew, a lot of these systems rely on not just having a smartphone, but actually carrying it around. Is there any evidence of gender differences? Because it seems to me that men carry their phones more than women.
Yeah, that's an interesting point. I think I haven't seen any analysis by gender. Most of the analysis has been by income and by age. It seems that gender is not sort of statistically significant in terms of determining that one gender or some genders are more likely to carry their phones than others. So really the concern is more around young people, old people, and then poor people effectively.
Thank you. This is possibly one for you, Susan. Why is the SDHB not using the COVID app QR code?
Okay, well, I think Andrew did a good job at highlighting the limitations of that. First of all, we'd have to need everybody across the district, 334,000 odd people, to all be downloading it and then using it very regularly. I think right now, because the heat is off in terms of the number of cases, people haven't been, the motivation to use it is not quite there. But as Andrew also pointed out really well, this would be an adjunct to our normal contact tracing systems. We would still be calling people, and yes, if we could get one or two or a few more contacts through using the app, that would be fantastic. But right now, we're not going to be relying on that.
Okay, thank you, Susan. Ayesha, I think this one would be probably directed for you. In responding to and cooperating with contact tracing efforts, a certain amount of trust from the general public is necessary. How was this negotiated, and was there a specific approach in this regard for Maori?
What a good question. Yes, I agree with the premise that there's a request to the community to get information about where they've been, and some people may not want to disclose that. So good public health practice requires trust for the contact tracing to be effective. And look, I can't say there was a specific effort to try and achieve that, but I guess I'd point to the efforts made to, by officials to explain the process, and then I felt I had a role in trying to flesh out an explanation for the public via the media about what contact tracing was as well, so that if you were being contact traced, that wouldn't be a wholly unexpected or unfamiliar process. I think, and you'll recall that on one of my slides I mentioned good contact tracing is embedded in communities, and one of the important things then when I wrote my report was making sure it underscored the importance of public health units as the primary nexus where this is going to happen, and not an entirely call centre centralised process, because in public health units there are numerous public health officials have relationships with the community. They know rest homes from previous outbreaks. They might have relationships with all parts of the community. So I think an emphasis on public health units helps build that community level trust much more than a centralised system, wholly centralised system would. And then I think with respect to a focus on Māori, I think as a overall, it would be a fair criticism that wasn't an emphasis early on, but I think the opportunity to think about how in preparing for a new outbreak we would make sure we were responsive to Māori would be thinking about things like rather than having, well, firstly having engagement with Māori at the local level where public health units are planning for future outbreaks, but secondly potentially working with other Māori health providers to train contact tracers who are working in other health services in the community at the moment, and then when there is a surge in cases, activating them as contact tracers. So that's a potential aspect thing to look at in the future, but I agree hasn't been looked at enough now.
I just wanted to add something just in terms of other populations that are particularly at risk. So migrant populations have been groups that have been particularly pointed out as not necessarily willing to participate in contact tracing systems, particularly Pacifica and also Chinese. And so I believe that the Ministry of Health has been considering how it can do that sort of outreach, and that includes things like providing translations for materials and providing the NZ COVID Tracer app in different languages to help educate the public and educate those communities about why they should probably participate in these systems.
Thank you. Here's a kind of a comment, kind of a question, which relates to what you just said. I'm interested in the speaker's views on equity issues in relation to the Ministry of Health's app. It seems that many people cannot download it onto their older phones, and these are likely to be the most vulnerable.
Yeah, and I think this is what I was talking about in terms of whether you want to take a universal approach or a targeted approach. I think the Ministry of Health always knew that their solution was not going to be usable by 100% of the population. And I don't think anybody would have thought that it would, but the messaging that was given out sort of gave the impression that it would be a universal approach. And so I think that at least the feedback that I've given to the Ministry of Health on this is that they need to understand who is missing out, and making sure that there are alternative methods for those people to be captured by the system in some way.
Thank you, Andrew. Public health experts blog today calls for consistent and correct use of isolation for people with confirmed infection and quarantine, keeping potential contacts separate from others with daily checks. What would be the benefits and harms of changing the way terminology is being used at the border? Any of you?
Maybe I can take that one, Jackie. Yeah, I think this has been a very confusing thing that's happened not only in New Zealand, but across the world, this interchange between the using isolation or quarantine. I guess for pragmatic purposes, it does mean the same thing. It's just that you're doing it for slightly different purposes. So you're wanting people to remain in their homes and not to be in contact with other people. So yes, we could go through and try and educate people on the finer points of the difference. But I think the general concept is we want people to stay at home if they're a case or if they're identified as a close contact. And the whole purpose of that is so that we don't have onward transmission of the disease. Ayesha, might add something.
I was going to say, I think the ship has sailed on that, and next year's thesaurus, you'll have quarantine and isolation next to each other.
Yes, I agree that our opportunity to stand up for proper terminology is probably past, but I think when I reflect on some of the inability to some of the difficulties there's been communicating the actual risk from the lapses in border management, and that the actual risk is very low. I mean, that relates to this difference, doesn't it? When the difference between isolating people who are sick and infectious versus people who are at risk of infection, and the risk is very low. So perhaps if we had been ahead of the curve on that one and represented the terminology correctly, perhaps people might have grasped that, but it's not really something I feel can be addressed now.
Well, the person who asked the question says, great answer, so thank you to all of you. One last question, how well are the contact tracing apps such as Ripple and the government one being integrated, and how well are they working? Andrew?
Yeah, so there's a long answer to this. I think the trouble is that basically we don't really know. And there are two key reasons. So one is that there's been fragmentation. And so we can see the statistics for how the NZ COVID Tracer app has been performing. There's about 10% of the population's downloaded. They're sort of 20,000 QR code scans a day. But we don't know what's happening with any of these other systems. So Ripple is not reporting its statistics daily. And a lot of these systems that are decentralized, there are no statistics to report. So it's hard to estimate the effectiveness. And then the second part of it is that we're introducing these systems at a time when our case numbers are dropping. And so part of it is the psychology that people aren't really thinking about this, or they don't feel like they need to do it. But also the ultimate measure of effectiveness is whether it's reducing contact tracing times. And when we don't have many cases, we can't really measure if it's reducing contact tracing times. So at this stage, it works in theory, but we'll need to stress test it, I think, and really do some scenario testing to see if this sort of tool is actually helping or not.
Okay, so time will tell. Thank you very much to all three of you, Dr. Ayesha Verrall, Dr. Susan Jack, and Dr. Andrew Chen. And that's all we're going to be doing today. We will be back again tomorrow at 12 for day 8 of the COVID-19 Masterclass. Ngā mihi.